I'm really excited to introduce my mentor and friend, Dr. Alister Martin. Um, Dr. Alister Martin is faculty at the MGH Center for Social Justice and Health Equity at Harvard Medical School and founder of Get Wavered, a campaign aimed at transforming ED's emergency departments nationwide into the front door for recovery for patients with opioid addiction. This work serves as a national model at the NIH with several state partnerships, including Get Wavered Texas and Get Wavered Nebraska. His work has been written about in the Boston Globe, NPR, and JAMA. Alister came to train at Harvard after working in state health policy and after getting an MPP from the Harvard Kennedy School of Government, where he was a fellow at the Center for Public Leadership. In 2013, he accepted a position as a health policy aide to Governor Pete Shumlin of Vermont, given that state's ongoing transition to a single-payer system at the time. Over the subsequent year, he led a team in the governor's office responsible for building the communications plan for Vermont's proposed single-payer plan called Green Mountain Care. Alister previously served as a chief resident at MGH Brigham Hospital. He now leverages his background in politics, healthcare policy, and the field of behavioral economics to use the ED as a place to build programs that serve the needs of vulnerable patients. He leads programs that transition homeless patients into permanent supportive housing, get patients struggling with addiction into recovery, and offer patients who are unregistered voters at the opportunity to register to vote through a program called Vote ER. Welcome, Dr. Martin.
Thank you very much, Kelly, and thank you all for inviting me. Really excited to be here, and we're going to get into some case studies today. We're going to get concrete and talk about where the rubber meets the road when it comes to advocacy and the different options that you have when you identify problems. And by the way, you're going to identify problems. I'm not saying if you identify problems in healthcare and in medicine. It's not a question of if, it's when you identify them, what are you going to do about them? Before I start, I want to share something that I've learned from Dr. Paul Farmer. Dr. Paul Farmer talks about the delay. The delay is the gap between when a good person sees something wrong and chooses to do something about it. The delay is between when a good person sees something wrong and chooses to do something about it. And he says that people die in that delay. And so today, we're going to give you some tools. Why? Because I think that the biggest driver in the length of a delay is powerlessness and feeling as if you have no options, feeling as if there's nothing you can do anyway, so why should we even try? Today, we're going to talk about a couple different things that you can do and a couple different ways that you can show up. Now, I'll start by saying that this is certainly not an exhaustive list of tactics or strategies, but we're going to get right into it. And we're going to talk about my two favorite strategies, which are pressure campaigns and coalition building. And let's get right into it. We're going to start with a case study. All right. This is not a hypothetical. Actually, let me ask, is this recorded? Damn. All right. I may have to change some of the names. Totally fine. All right. So here are some options. And again, as I said, initially, this is not an exhaustive list. But this is going to give you a couple of different you're at the fork in the road. You've identified the problem. Now, what are you going to do about it? Of course, doing nothing is always an option. But that's not why you applied to medical school. That's not why you grinded out through step one and why you were kind of grinding out to step two. Nobody really grinds to step two, but you know what I'm saying? This is why you decided to do this work of helping and healing others. So doing nothing, yeah, you can try that, but you may not sleep that well at night, right? Number two is pressure campaigns. And we're going to teach you a little bit about pressure campaigns and how to power map in a second. And then number three is direct service. And we'll talk about what direct service actually means.
And I think Georgia might have been hinting to direct service a bit, mentioning you could reach out to doctors, nurses, other people you know in your professional network, or other people in local government.
Excellent. All right. So before I tell you about what we did to begin with, I want to tell you a quick story from another campaign where, again, I didn't really have the time to be mobilizing, but at the end of the day, you have to make the time, because a lot of the times you're going to end up in a scenario where no one is doing anything about it. And so you've got to be the one to at least get the ball rolling and get things started. So here's the problem. The problem was, this is back in the beginning of COVID, right around April. I was sitting in my faculty meeting when this woman from outside of our department came and presented this slide. And she said, look, we're now running low on ventilators. There were shifts where I had to intubate 12 people in one shift. So I understood what she was describing. And she said, we have to now transition to a new standard of care called the crisis standards of care. The crisis standards of care are going to be the following. If your patient comes in and needs to be intubated, we're now going to score them for points. We're now going to score them for points. Every single disease they have, they get 1 point. If they have a number of diseases, they get more points. The more points they have, you know where this is going, the less likely that they are to get a ventilator. So let me just close the link there, okay? The more diseases they have, the less likely they are to get a ventilator. And this is the list. Bro, diabetes with end organ involvement. If you have diabetes and you have blurry vision, boom. Oxygen-dependent lung disease, cirrhosis, CKD. Okay, now I want you guys to think about this, because you're smart and you're in this advanced health policy course, you understand. I'm sitting in a room full of 50 other doctors, and we all see the same slide. Nobody says anything. Can somebody tell me what the problem is with this slide?
I mean, clearly this is going to impact communities of color mostly tremendously, because most of, a lot of these comorbidities affect our community the most, right? Hypertension, diabetes, cirrhosis, COPD. Most of our community, unfortunately, has been affected by this. So, and obviously there's reasons why we have such bad, One Health literacy, and obviously communities with, we could go on and on with that, but we're going to get significantly affected by this. So we're going to get less.
I like that. And also I want to move the locus of responsibility to some extent away from health literacy and towards racism and the structural and social determinants of health that impact communities of color and their ability to get healthcare, right? And so we have, in effect, created a system that sets you up to fail in the first place. And then when you come to us sick with the disease that hits your community more, because you're still at Target bagging groceries, we're now going to say to you, no, you're good. You don't need that.
And Joanna, I want to give you space to chime in here. I see you raised your hand.
Sorry, that was an accident. My bad.
It's all good. All right. So, so that was the problem that I was confronted with. This is back in April of last year. And so what did we do? We began grassroots mobilizing, sounding the alarm on Twitter, getting physician sign-on letters with physicians all across Boston and Massachusetts signing on to the idea that this is absolutely inappropriate. We must change these guidelines. The state has to revise them before we're in the situation where we actually have to put this out there. But we also started mobilizing at the grass tops. Why? Because unfortunately, you do still need to have folks who are authority figures singing your tune and making sure that they're saying the same things that you are. So we partnered with the Massachusetts Black and Latino Legislative Caucus, mobilized them. We wrote a joint letter together. They needed physicians, we needed policymakers. We partnered with prominent policymakers like Joe Kennedy and Ayanna Pressley. They also put out statements similar to ours. I went on TV, as well as many of our physicians in our coalition, to sound the alarm, to point out that this is absolutely inappropriate. And we succeeded. Okay. 3 weeks later, from the beginning of when I was sitting in that faculty meeting, 3 weeks later, the state revised the guidelines. And I didn't get fired, which is a whole different talk. How do you rock the boat while staying in it? That's a different talk. But this is the talk around pressure tactics. So what did we do? We power mapped. So what is a power map? Power mapping is a framework for addressing issues and problem solving through leveraging relationships. Effectively, you're trying to identify who do you need to influence, who can you influence to then influence the target, and who do you sort of begin to engage with to sort of begin the dominoes falling one by one. Who is the first domino that needs to fall? And effectively, what we're trying to raise up here with power mapping is that networks of relationships are probably the most critical resource you're ever going to have when it comes to doing organizing work. Networks of relationships are the most important resources you're going to have when it comes to doing organizing work. So why should we be doing power mapping? Well, we got to understand a couple of questions, right? When it came time to trying to get the state to revise the guidelines, I had to answer the question Georgia asked. Ultimately, who has their hand on the pen, right? Who has the power to say, yes, we're going to revise this? Who has the power to say, get these doctors out of here? They don't know anything about what they're talking about. What do we need to do to win? How much pressure do we need to apply? How much praise do we also need to apply when things are starting to go well, right? So sort of beginning to understand where are the intervention points. Number two, building a power map allows us to build power among allies and collaboration. And then lastly, it gives us an opportunity to reveal points of strengths and weaknesses where we can begin to push. So there are 3 steps to power mapping. Okay. This is, by the way, this is like an hour-long talk. I'm going to condense this into about 10 minutes. So if there are questions, please ask. Step 1, you have to choose your issue. And the issue has to be very, 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 very clear. You need to understand what is the problem that you need to solve. Okay. I'll give you 2 examples. Why are we doing this in a case study format? The first example was the map. These people are dying here. There's no vaccine sites here. That's a problem. That's an issue. Issue 2, we have folks who are from communities of color who are dying disproportionately because of COVID. And now you're creating policies that don't let me take care of them. That's an issue, right? The questions you then have to ask are is it winnable? Is this something that you can revise, reverse, change? Is there a decision maker, and is there a clear understanding of how we will know that we've won our campaign? Number 2, is it transformative? The reason why I say this is because, the work that I end up doing often, these 2 projects are just 2 examples. They rely on people volunteering their time, not getting paid. Folks have kids. Folks have research letters they need to write. Folks are reviewers for journals. They have a lot of other things going on. And so people are not really motivated to do like mediocre stuff, right? If you're mobilizing, you have to figure out what are the ways in which this work can and could be transformative. And then lastly, does it build power? Why? Because we need to organize ourselves out of a job. We need to, when we leave this issue, the people around us are stronger and they can begin to do this work on their own after the issue's over.
Can I ask a question there?
Yes, please.
Define winnable.
Yeah.
The optimist activist in me says everything's winnable.
Yeah. Well, that's a really good question. I think it depends on what the issue is. And it's up to you and the group to decide what is winnable for you in this circumstance, right? So sometimes winnable is like, getting vaccines into the community by any means necessary. And we'll get to what some of that means in a sec. Sometimes Winnable is like, they just need to change something about this to demonstrate that this guideline, they need to change something about this to demonstrate that they are open to hearing our perspective, right? And so I'm going to take you one level deeper into the sort of the mind of, because you guys are going to be lead organizers, okay? You have to pace your team and you have to give them small wins, right? Because this work is hard and it's difficult to do this long term. And a lot of it is like, you know, you get stuck in long sort of trench warfare. And so you've got to figure out, are there specific sub campaigns that can be moments of celebration for people? So it's not a straightforward question. It's a highly contextual question. But basically, you having a discussion with your team up front to decide what does success look like here is critical, super critical. All right, so step 2, identify the target. The target is always a person, and the target always has the power to say yes to the demand. This last piece is incredibly important. I think most people understand this intuitively. It wasn't until I was a chief resident that I understood this, okay? Because I was the target, by the way. Like I recognize when people are running game on me. The target will often, but not always, have to pay a cost to say yes to you, right? There's going to be something that has to be given up, whether it's, you know, they have to give up face, or they have to, you know, give up money, or they have to give up credibility, or they have to give up, like, they were the person who had all the answers and now they got that wrong. So now they have to sort of concede a little bit. The bottom line is there's always a cost, and you need to understand that cost. What comes up often is some people ask, well, what if there are multiple people, like a committee or something like that? What I'm going to argue for here is that even when there are committees, typically, if you power map well enough, you know who the person is who actually holds sway in that committee. It's possible that all of them are the same formal rank, but I promise you there is one informal leader, and understanding who that person is and how you can motivate them and influence them is incredibly important. Okay, last step. So you've picked your issue. You've identified who the decision maker is. Now you need to figure out what is the universe that surrounds that person. We call these people influencers, okay? So it's your target, and then you've got influencers around that person. So who are some different sort of types of influencers? Well, there are a couple categories. I frame this to be a hospital, sort of medical school focused power mapping session, but you know, this applies if you go and work in state government, or if you go and, you know, work in the nonprofit sector. But for the hospital setting, number one category are folks who are inside the department. So faculty, program managers, secretaries inside the department that you work in. You just went to a family medicine, you just matched a family medicine residency, fantastic. Start mapping your department right up front. Figure out who has informal authority, who has formal authority, but nobody really listens to, because you know there are those people, right? And figure out how you're going to begin to understand how to make change in the department. Number 2, relevant staff outside the department, like the PR office of your hospital, that's public relations office, DEI office, development office, community affairs, etc. Okay. Personal influence is a third category. Who are the folks who are significant others, family members, friends that surround that target? 4 VIPs, so trustees, public officials, board members, etc. And then lastly is the public, right? So you've already seen, hopefully you're beginning to sort of see how this is working together, right? So what was I doing when I was on TV? Hitting an influencer through one of these channels, right? Through public. When we were mobilizing Robert Kennedy or Joe Kennedy and Ayanna Pressley, what were we doing? Mobilizing VIPs, right? And so you begin to see how by applying these sort of targeted pressure, you begin to change the way that decision makers have to think about the calculus of saying yes or no to you. All right, so here's the traditional view of power. The traditional view of power is that you have a powerful individual up top and power flows down. If this is the mind frame that you have, I promise you, you'll never get any substantive change done. I'm here to tell you that this is actually incorrect. This is the way that power works. This is the way that power works, okay? A person in power is only there because of his or her supporters. I'll repeat it. A person in power is only there because of his or her supporters. When you know who those supporters are, when you've identified those pillars of support, you can then begin knocking them out, threatening their power. Okay? So if you really want to start to make change, you have to understand how to diagnose sort of who the influencers are, what their connections are to the decision makers in your issue, and how you can begin to mobilize against or with them. This is an example of what this looks like, right? So let's say you're at your school and you're trying to get, well, this happens all the time. We do this with ODR. You're trying to get your school to say yes to doing voter registration tabling events, right? And your dean is the person who's ultimately the decision maker. Well, you've got to figure out who's in your dean's universe, and who do you know in that universe that you can push to go have a one-on-one conversation with the dean. I'll show you a very clear example of what this looks like in a sec. So before I move on to what we did, I want to pause there because I've thrown a lot at you guys. We're about to, we went case study concrete, we went theoretical, now we're going to come back to concrete. What questions do you guys have? And if there are none, that's totally fine. But I just want to let people breathe for a second.
I would just add a comment that in this power mapping process, it doesn't just have to be you. In the environment you enter, there's already someone who's existed in that environment before you. I don't care if you're at a brand new medical school or a new residency program, there is someone there who knows more than you do, especially in the trainee space. So take cues about where power exists based on people that are already there. Like the world doesn't have to fall on your shoulders.
Love that.
Also, I wanted to say a comment. This really aligns well with our stakeholder analysis workshop last week as well. A lot of these principles, like you want to use both of these side by side when you're identifying essentially who to target.
Perfect. We didn't plan that either. All right, so remember, back to our case, right? Got a map. The places where you saw COVID patients die the most are exactly the places where there are no vaccines, right? So what did we do? I chose first to start with a pressure campaign, all right? And I was part of a coalition of healthcare providers because we had already organized previously for the crisis standards of care work. So we already had organizational capacity. And this is the important thing to remember. When you do this work, again, trying to organize yourself out of a job, you need to make sure that there is capacity that's left over that remains after you move on to the next thing. Why? Because when this happened, we already had a network and it was already time to go, you know? So this is what we did. We started with a pressure campaign. And this is the governor. We did power mapping. We figured out who are the different folks in his universe. How do they connect? For those folks, how do we connect to them? And can we get a one-on-one with them to push the governor? And so we did that for the first, I'd say 2.5 weeks, pushed forward on this map and made some progress. We created a sign-on letter throughout the state of Massachusetts, directed directly to Charlie Baker, Mary Lou Sutters. We did some social media organizing. Eventually we got the Boston Globe to cover it, which was a really great moment. And guess what? Nothing happened. And we pushed and we pushed and we pushed. And I would say after about a month, the governor, it was very clear, there was something going on where he wasn't really in a position to listen to what we were saying. And it might have been that he felt like he'd already solved the problem, or the problem wasn't grave enough, or that maybe they were coming up with solutions and he felt like he didn't have to say anything because the solutions were on the way. But the bottom line is there was no change. And ordinarily you might continue the pressure campaign and continue escalating pressure. But the bottom line for us is we didn't have time for that, because literally, every single day that passes is another day where these folks don't get access to a critical resource, which is the vaccine that could save their lives, right? So we made the decision to switch from pressure campaigning to direct service. And this is what we did. So we created a program called Get Out the Vaccine, which is GOT-VAX. Really cheesy name, I admit. But it communicates what we're doing, right? So number one, we apply traditional GOTV campaign strategies like text banking, phone banking, canvassing, door knocking, right? Except that we don't use sort of volunteers that just like working on campaigns. We use healthcare providers to do these things. We have campaign managers and field organizers who oversee them, basically give them direction. And we deploy them in the second ingredient here, which is Boston Housing Authority low-income housing units. So these are low-income housing units in those 3 neighborhoods. There are about a dozen or so just in one of those neighborhoods, about a half dozen in another, and then another handful in one of the other neighborhoods. Then the last piece of this pie is we bring vaccines to those housing authorities. We actually bring the vaccine physically to that lobby and vaccinate people right in their housing unit. So what does a typical day look like? Well, we just had a campaign yesterday at a Boston Housing Authority complex in East Boston. Our organizers and physicians and medical students knocked on 650 doors, woke some people up for some of them, and got them outside of their door and brought them downstairs, got them vaccinated. And for the people who weren't able to get out because they're immobile or had limited mobility, we brought the vaccine to them, right? And so the groups that we mobilize here are organizers. These are people from the community who've run campaigns in these areas, 2 healthcare workers who can speak credibly about the vaccine, mostly Black and brown folks. And then lastly, this is our secret weapon, neighbors who've already gotten vaccinated. These are folks who are way better messengers than I could ever be, because many of them, have spoken to their neighbor for years already, and they've already built trust. And so having Grandma Jane come by and talk about why she decided to get the vaccine is probably more powerful than me doing it. And so what are the results so far? The results are that we have vaccinated a couple thousand people so far. And I want you to just focus in on this. The average household income of the folks that we have vaccinated is $16,000. That's not individual income. These folks are living in poverty. They're not hopping in an Uber and going down to the local community health center. These people need us to make it easy for them. They're not accessing a site. Many of them are, 65 plus. They're not accessing the site on their iPhone. Many of them don't even have internet, right? We've done weekly mobilizations and mobilized over 200 physicians and medical students to come and do these volunteer canvassing shifts, and have gotten lots of folks vaccinated. And importantly, one thing that I've come to learn is you can't just go from one issue to the next and put out fires. You have to also, when you're trying to solve the problem, build sustainability long-term. And so what we do in the post-vaccination setting is we actually get people registered to vote, because we know that 50% of the people who we are vaccinating are not registered voters. And we do that with VoteER. Quick plug for that. This is an organization that has nationally over 300 participating hospitals, 46,000 or 26,000 healthcare providers who wear one of these. Many of you may have your own, or if you don't, I'll drop a link in the chat. that helps you get registered to vote, or helps your patients get registered to vote. And so our canvassers have these, they wear them when they're out there vaccinating people. And in 2020, we helped over 46,000 patients with voter registration and mail-in ballots. All right. We covered a lot of ground. I want to do one more thing, but before we do it, I want to take some questions. Any questions that folks have?
I would like to know what barriers you encountered, because you're making this seem very streamlined and like it just worked. What side steps did you have to take in this seemingly linear journey?
Yeah. Let me actually just stop there. And if we have time, if folks don't have any more questions, then I'll transition to what I was going to do. But I think it's important to unpack this, this campaign. So what barriers do we have? I mean, the whole thing was a barrier. Like, I don't have access to vaccines. Like, you know, like figuring out how I was going to get access to vaccines, how I was going to make sure that we had someone to give the vaccines, make sure that we had a site where we could actually do the vaccinations, make the organizations we're working with feel comfortable that we can use that information, that data, that patient data, and use it in a way that is trustworthy. So there were a lot of challenges. I would say probably the biggest challenge, the biggest challenge is really identifying partners that see the same vision as we did, because this had never been done before. And so they were many folks who believed that it was important to promote health equity, particularly around vaccine access. They believed that this was important, but they were scared to do it the way that we're describing, because it hadn't been done. Like, bringing these vaccines into a public housing unit was like unheard of. And so we had to work pretty hard to find a community health center partner that was interested in doing this. And, you know, we got told no a lot, which is just part of the process. And so that was the first. The second is finances. Like, you know, to begin with, these EMS providers who were doing the vaccinations, they had to get paid. So, like, am I going to let the cost be a barrier? No, I paid for it, right? So initially, I basically funded this because I knew, number one, it was the right thing to do. But I also knew, number two, this was going to work, and that pretty soon we were going to get the funding to pay for this to scale very quickly. And so I think that was the second challenge. And then three, I think, is the traditional challenge of like hiring good people. I found that like that skill is like nobody teaches you that in med school. But hiring good people, I think, is always a challenge, and particularly when, like, I've never run a campaign before. So when I'm interviewing somebody to run the campaign here, we looked for a campaign manager for a while. I was trying to identify these skills in someone else that I didn't have myself. So that was the third challenge, I would say. But each of these challenges are surmountable.
I think you might be able to read Melody's question here, but I'll read it aloud for those that aren't. You mentioned that there's a fine balance between making sure you are a part of the solution to what you feel needs to be fixed with not getting fired. As we're going to be resident physicians soon, what is your advice on how to balance this and make sure you're not crossing a line or don't cross a line?
Yeah.
Especially because all of what you've addressed in terms of necessary campaigns are because you perceived a need on the ground, right? It's not anything that's outside of the best interest for patients. So it's a tough tightrope to walk.
Yeah, I mean, I have to start by saying that the first and most important and potentially unintuitive thing you have to remember, or maybe I'm just different and I think about this in a different way, but here's how I do it. I remember that most of the time, these are good people who are just trying to do their best, and they're tired and they're dealing with their own stuff, and they are struggling to get through a day too. And so like they have blind spots. And if I come in thinking about this as like, yo, you intentionally did this and you're doing it because you're so careless and insensitive and boorish and you don't get this, like already my energy's off, right? So understanding that actually some of the people who I'm trying to mobilize are the opposition, like the people who I initially cast as the bad guys. If I stay in the bad guy framing, I get in trouble, because that's when you start, getting personal and start like really, doing things in a way that calls out their character. And like that is there's a difference between external game and internal game. The external game, that's fine, right? So external game means like if I'm in an institution, I can like mobilize people to talk about some external stakeholder, like policymakers in the city or county that I'm from. And that external game is like, you turn up the heat by, mobilizing the press, getting sign-on letters, protesting, etc. The internal game is if I'm in that same department, that same hospital, and I'm trying to mobilize my chair, I don't have as many of the opportunities to leverage, the press and the walkout and the protest, because in that space, it is harder for me to do those things and stay in the game. So there are different approaches to the game, right? So you have to figure out first, where are you? Are you playing inside game? You're playing outside game. Inside game generally is where you're trying to really empathize and put yourself in the decision, in the perspective of the decision maker, to understand what was it that compelled them to make this decision, or to not make the decision you want them to make. And I find that with the internal game, the more you understand, the better you are at helping them to change their mind. On the external game, the more you turn the heat up, the higher the likelihood of success. There's definitely still empathy involved there. Let me just say that. So I would say that to just put it really clearly, remember that when you are dealing with your residency program, like your chair, your program director, your chief residents, just remember that many of them are really good people and they're kind and they're trying to do their best, and they've got blind spots. And if you approach it from that angle, I think you stay out of trouble, right? You stay out of keeping it personal. The second piece of advice I would give is come to people with solutions. Like there's something to be said about like identifying the problems and raising hell about the problems. And you get like one or two of those. And if you're Black or a woman, you get like one, you get like 0.5, right? So you can't just be like bashing the problem. You have to bash the problem and say, it's a problem. A lot of people acknowledge that this is a problem, but I got it. Here are the ways that I need you to help me to move forward so I can take this problem off your hands. And so think about it like that, right? Like you get like one bullet in the chamber for like a complaint or a problem with no solution. I still haven't used mine, by the way. All the problems that I've come to my chair, my department head, or my CEO for, I've had solutions for them. I've sequenced it. I know that I'm not going to meet with this person unless I know what the next step is, right? And unless I know what the next thing I want to ask them for is. So I'm sorry that kind of went on, but that's a sort of real answer to that.
Yeah, because that's a very real fear that I think we all share with you, Melody. Wanting to be an activist in systems that were not designed for us to be that. But just knowing what tools to use in what environments, I think is a really, really good piece of advice. We are coming up on our last few minutes here, so I don't know if you wanted to continue with some of the slides you had, or if this is just kind of an open Q&A space right now.
Yeah, let's keep it open Q&A.
Okay.
I have one ask for people, and that is what I was going to show you was actually, let me do one of them so people have a sense of where we're going. So I want folks to just take 30 seconds and read each of these questions and ask yourself, how many of these could I reasonably get right? And when you get an answer, if it's 0 or 2 or 3 or 4, put it in the chat, like what your number is. So I'm going to put mine in here. Okay, the average right now is about 1.7. Seen a couple 2s, okay. All right, so you guys have not taken got a couple 1s here. Here it is. Yep. You guys have not just taken a senior level government and politics class, okay? This quiz doesn't represent a graduate school level questionnaire that you would take on entrance to a graduate program. That was a Georgia literacy test. You had to get every single one of those questions right to vote in the state of Georgia in our parents' lifetimes. Okay, so I'm leaving this in the chat here because I don't want you to think that the battle for who gets to vote and who does not get to vote in this country is over. It's still ongoing. They call it different things. But at the end of the day, you've got to decide what side of history do you want to be on. We are physicians in training. Some of you already, have multiple master's degrees. You are empowered. And I feel, and many of you probably agree, that those who have power have one job, and that is to empower others. And there is no more important way that you can empower others than by registering folks to vote. That's all I got. Get your kit. It's free.
Yeah, it is. I definitely got mine. All right. We want to thank you for this session today, Dr. Martin, because it actually pulled together a lot of the themes that we had addressed in this elective. And it was intentional to bring you into this space and create this thread around mapping power, how to leverage power to actually act when you see an issue. A lot of students in this elective have been made aware of issues through the elective, right? So even if it's not happening when you're on the ground delivering care, you've been made aware of current events and current issues that you can be advocates for. You don't have to don a white coat yet if you're a pre-medical student in order to be an advocate or take any of the steps that were outlined today. You don't have to have done the degree yet in order to do any part of what Dr. Martin outlined today. So I really want people to feel empowered to engage in campaigns, either to assist existing ones or to start your own where it's necessary. So thank you for giving us that power today, Alister. We appreciate that.
Thank you very much, y'all, and really appreciate being able to share the space with you. Please reach out. I'm gonna drop my email in the chat, and I would look forward to working with you and seeing the incredible things that you guys do.